Grüße aus der Schweiz. Yeah, we can pass it.
Oh no, there's two. Here's one.
So we will have our
Testing.
next talk this morning.
Testing 1, 2, 3.
Soll der Robin nicht auch hier oben sein?
Ja, da, ja. So we need our friend Robin.
Here he is. Yeah, come up to the front, Robin.
John, has anyone seen John? John Trent?
Yeah, I think wherever he is in the moment.
We can go ahead.
Just we don't have any time pressure at the moment. Maybe we can wait 2-3 minutes. It's fine.
Morning, John. Morning, Robert. Have you seen John? I think so.
I can text John now, maybe just to.
So our Italian colleague, is he still online? Is he online? Okay.
Hi everyone, I'm here.
Just wait. I think we need Jonathan, and then we can.
So I text John.
So when we have had yesterday, we have had this sarcoma discussion, and then we called the guys on the stage the boy band. Now we have partly another boy band. So there was a boy band, I think, 100 years ago, New Kids on the Block, and now we have the new kids on the block now.
Not really new in the business.
No, and we have one boy group member online. Yeah.
I'm sort of flattered to be the youngest in the.
You are also a boy group member from Spain, or? Good. So, I have no idea where Jonathan is. Maybe we should already.
Sent him a text message. But
Okay. So we should start. When we just came to the stage.
Okay.
We just have had a discussion. It looks a little bit like storytelling. So sitting beside each other. And so we have to start with, what is the official term? Once upon a time?
Once upon a time.
Now it's your term.
Are you all seated comfortably?
That's Marco. Hello, Marco.
Hi there.
Oh, hello, Marco.
Hi, can you hear me?
No, he can't hear us, I think.
Can you hear us?
I can hear you very clearly. Can you hear
We
me?
can't hear you yet.
We can't hear him.
This is a typical Zoom story hour.
We've been through this for a few now.
almost unexpectedly. A fourth set of another constituency involved in setting research priorities are the funding agencies themselves, like the NIH in the US and Canadian Institutes of Health Research and various Forschungen in Germany. And they may have their own take, their own view of what the research priorities are. And now we're trying to bring in, as many is happening in many areas of research, now we're trying to bring in a fifth priority setting agency or consortium, and that's the patients. And until recently, patients have had very little voice, very little input into research priorities. And so that's really the focus of what we're trying to do in this session, I think, this morning and also this afternoon, is trying to give the patient view of research priorities. And I don't want to say that that is necessarily superior or inferior to the other constituencies that I've just mentioned, academics and clinicians and so on, but I think it will very much help to inform where we think research priorities should be set, okay?
Okay, so
And I have one more set of comments after I take a sip of water. Like most professors and ex-professors, I usually start talking and don't stop for 1 hour, but I'll try to keep it shorter than that. So the last thing I wanted to say in introducing the topics this morning is that I think the patient view also brings a new perspective in the following way, that as far as an academic is concerned, once they get the paper published, the work is done. And it may be true to some extent that from a clinician perspective, once they get the clinical trial reported at ASCO, the work is done, the data's there. But I think we really recognize, and it very much came across yesterday, that that's not the end. It's barely even the beginning. From the patient point of view, what we're concerned with are global patient outcomes. And there's a huge gap, there may be a huge gap between the research and the clinical trial and the published results on the one hand, and real patient outcomes, real world evidence on the other. And we saw examples of that we now have remarkable, effective new drugs. The clinical trial results looked beautiful. The publications will look beautiful. But if there isn't a single patient in the world who actually gets those drugs, how does it help us? And we see there's a huge barrier to making these drugs available and affordable. And the other last example I would give is mutational testing. It was now, by my count, 15 years ago that we met in Baveno, Italy, and put together the Baveno Declaration and said that simple mutational testing of biopsy-just tumors should be available to every patient. 15 years later, as we heard discussed yesterday, that's still far from the case, even in the USA, let alone in other countries. Well, actually, other countries are ahead of the USA and Canada, but it's still far from universally implemented, even in developed countries, let alone around the world. And we also heard yesterday, we saw results from people like Dr. Trent, showing that even biopsy mutational testing is now being left in the dust. It's being left behind now, or will be left behind perhaps, by circulating tumors, ctDNA analysis, which is another generation of research advances, even beyond simple mutational testing. And yet here we are in 2023, still fighting to get simple mutational testing and classification of KIT versus PDGFRA versus SDH. We're a long way even from achieving that. So I think the patient voice will very much focus our attention on the importance of translating fundamental discoveries into real-world evidence. So with that introduction, I'll turn it back to Marcus.
Okay, so as David already mentioned, we have collected a lot of questions with a survey from our colleagues from the patient advocacy community. Several hundred, I don't know, 200 roundabout questions came in. And some of the questions had been related to advocacy, that had been not research questions. Understandable, because they are patient advocates with all their challenges. Some of the questions had been related to information education, because it had nothing to do with research, but we also have seen a lot of questions related to research. And our task today, this morning, is to comment on some of these questions, but not to just push them away, but to take these questions really serious. And what do we know? Maybe what is really an open research question. And we have done this in different blocks. So the first block is, and we collected these questions on the 10 most frequently mentioned topics or areas, where we have had areas where we received many questions to these areas. So we grouped this a little bit. And then we have another block with 10 rarely asked or unusual questions. Hi, John. Morning. So just. So now, before we start into the first question, I think it's important. Many of you, I think 95%, know these guys very well, but we also have sometimes new people in the room, but also maybe online who don't know these guys. And I would give maybe everyone just a minute to introduce yourself, how you are related to GIST, because we know some of you, I would call them the dinosaurs of GIST. I don't know, something like this. So maybe just move. Maybe we start with you, John, and then just.
Yeah, I'm a sarcoma medical oncologist at Sylvester Comprehensive Cancer Center in Miami. I specialize mostly in GI stromal tumor in my clinic. We usually have multiple clinical trials open for GIST patients, and we have a translational and laboratory GIST program as well.
Peter Reichert, I'm a medical oncologist with a main focus on sarcoma, including GIST. I am what Marcus called one of the dinosaurs in the GIST business. I have to say, we've been among the first in Europe using imatinib more than 20 years ago. We've been definitely the first in Germany to use the drug. We have put hundreds of patients in clinical trials, especially the adjuvant GIST trial that defined 3 years as the ideal treatment. That was a European study with 400 patients, and 100 were put in my institution. That's a substantial contribution. I would say, followed all the developments. We've been participating in all major clinical trials regarding all drugs that are now available today, or maybe in the future. And I've been deeply involved in the development of patient advocacy activities in the context of GIST and sarcoma, which again is around 20 years in the past. So I'm not unhappy to be a dinosaur in this research direction. Thank you.
Robin Jones, I'm a medical oncologist at the Royal Marsden and Institute of Cancer Research in London, and similar to Peter and John, have an interest in sarcomas and GIST, particularly clinical trials for all the way from phase 1 through to phase 3, and have worked closely with patient groups, both the European, but also with Jane and Roger in the UK, and really pleased to be here today. So I'll be very concise as usual.
Thank you. And then we have our fourth member of the boy group. We just talked about boy group, new kids on the block now. And the fourth member of the boy group is Marco Baia. Can we just link him so that he can introduce him here? I think he's a surgeon from Milan, as I understood so far.
Hi everyone. Can
Maybe
you
we
hear
can
me?
hear him.
Hi everyone. I'm very honored to be here, representing sort of the Italian users group that's dealing with GIST and sarcoma. I currently work at the National Cancer Institute in Milan with Alex Gronchi, and I'm a 34-year-old surgical oncologist. So I'm just starting to develop my experience in this field, although I've been practicing quite a few years now. But I'm very interested to get all the possible feedbacks from you and from the patients regarding new perspective that research should be focused on in the coming years. So we're looking forward for our discussion.
Thank you, Marco, for taking the time. I can imagine that it's really challenging to follow such a discussion being online. So if you want to contribute to the discussion, please really let us know. So we don't want to do the discussion here and you are totally outside it. So please give us a link or give us a word whenever you want to be part of the discussion. And we also have some questions that are also more related, maybe in the direction of surgery or adjuvant treatment or something like this. Okay, so we start with the first block. Can we just have the presentation back? Okay. Okay, the main question or one of the first blocks, and I think this is totally understandable from a patient perspective, is the core question: what causes GIST, or what are the causes of GIST? And you can see there had been very similar question. Can research answer the question of what causes or triggers GIST? And then you all know we always have the story about the microGIST, so that there are microGISTs. What makes a microGIST a clinical relevant GIST or a potentially fatal disease? That's another issue, but also correlations between specific gene mutations and malignancy. And another is there a relationship between GIST and other sarcomas? So we try to group the questions somewhere in specific areas. So maybe who want to take on the first?
Maybe I can just comment on points 1 and 2, because in a way, there's something there, because microGISTs are relatively common in a way from autopsy series, that they can occur in 30-40% of people. And I suppose the question that I have, and it would be really good to get John, Peter, Cesar, everybody's thoughts on this. Looking at microGISTs, and I suppose the problem is that they're so small that actually being able to perform molecular analysis on these very tiny tumors to try and understand what is that trigger that in a smaller proportion of people causes a microGIST to develop into a clinically relevant GIST. And I think if we could look at those tumors, it would be very, very interesting. But I think the limitation is that they are so small, and being able to extract sufficient tumor material from them can be really, really challenging. But again, value what Peter, John, and Cesar and everybody has to say about that.
Well, maybe just to give an answer to the first question, I think we have to assume that mistakes in the genome do happen by chance, anytime in any cell. Most of them are fatal for the cell, so that will not cause any problems. Something goes wrong in the cell and that will kill this single cell, that's it. Some changes do not kill the cells, but they don't have any consequences. So again, that doesn't result in any problem. As we know, a mutation, an activating mutation in the GIST or PDGF receptor alpha, that causes GIST. So my answer to number one is we exactly know what is the cause of the disease with respect to genetic events that cause the disease. The question, why did this event take place in patient A, B, or C at that given time of his life? And the answer is that is absolutely unknown, and I would speculate that will remain unknown. These things happen. We don't know why, just by chance. And if you ask, because why did it happen to me and not to my neighbor who is always cleaning his car on Sundays and would deserve such a disease instead of myself? The answer is impossible to give. So it just happened. And when we accept that it just happens, then everything else rules out as a logic consequence. So that is all known, but the initial point, why did it happen in Mr. A or Mrs. B at that time, that is and will remain unknown.
I suppose my question is, why does that sort of transition occur from a microgist to a clinically relevant gist? And is there anything that we can untangle from these microgists in terms of the differences between those very small tumors and a clinically relevant tumor? But agree with everything that Peter has said. But there's that sort of question: why does that? What triggers that change? What triggers that change?
Yes, so I agree with all of the above, and would just add a couple of comments. And this meeting, we haven't, and at LifeFest, we haven't for a while talked about the familial or hereditary GIST. And so I have some patients in my practice where in their family, there's 15 individuals with GIST. And so this ends up being in a hereditary syndrome where there's a germline mutation in KIT. In this case, it's L579P. And that mutation in exon 11 is in every cell in their body. So it's not surprising when they have surgery, there's thousands of microgists. But then one of them turns into a malignant, high-grade, fast-growing, potentially metastatic GIST. And it turns out that some groups, I don't remember which group, but it was a number of years ago, and this group looked at, in single patients, compared the patient's microgist to the patient's malignant aggressive GIST. And the microgists we know are not malignant, as Robin mentioned, and I think it was a German study in trauma that showed that there was a 30% rate of microgists, and so like almost 1 in 3 people in the world have a microgist, but there's not that many GIST patients. So as Peter said, there has to be a second event. And in this study, what they found was that there was a gene called P16-INK4 that was mutated in the malignant GIST, but was normal or wild type in the microgist. So that's been implicated in a malignant transformation process. And then very recently, Inga Marie Schaefer's group at Dana-Farber showed an additional event in a gene called MAX, M-A-X. And so there are some of these that are known to be associated with the progression from microgist to aggressive GIST. But as Peter said, the cause of that, we don't know. We don't know why some microgists get P16 and some don't. It could be just random mutations that happen in all of our cells all of the time that are most 99.99% inconsequential, but every now and then one slips through our innate defenses and turns into a cancer. So I think that's one answer to that question. But I'll let the others continue.
I suppose one of the things, I suppose my question is there a series of events that result in that transition? And there probably is. And I think we don't really understand that well, John, in terms of what the series of events are, and whether there's scope for looking at that in a larger sample to try and sort of pinpoint what that sort of process or what that cascade is.
Yeah, so some groups have looked at the cell lines, the just 882, T1, and the 480 resistant line, and in the lab it seems like P16 and MAX are involved in the malignant progression, but that's in cell lines, and then the other studies that I'm aware of are in the hereditary or familial syndromes. But I'm not sure what's aware in the sporadic GISTs, and so I think that's certainly an area that would be ripe for research.
But in a way, it may even give us more information regarding the development of other cancers, if you see what I mean. What that sort of series of events is. So it's a really, really important question, not only for GIST, but for cancer in general.
I think another problem is that we do have these sequential events very nicely studied in colorectal cancer, where there are different steps and one follows the other. So that's a logic development. It's probably a little bit different in GIST, because just to remind, a micro-GIST is a very small GIST, few millimeters detected by chance. And there are two series, one from Japan. They take out stomachs because of early stomach cancer very frequently, because stomach cancer is very frequent in Japan. And then apart from the stomach cancer, which was the reason why the stomach was taken out, they find a couple of microgysts in approximately 25%. The other study was done in Germany, patients dying in a hospital who underwent autopsy. The patient died from anything, heart, stroke, whatever, and they underwent examination, and in these patients' stomachs, in 30%, a microgyst was found. On the other hand, most patients who have a localized GIST and undergo surgery do not have detectable microgysts around. So I don't think we can definitely claim that patients have many microgysts and one develops into a real GIST. We do have patients, as Robin already mentioned, and I just replied, 30, 25, whatever, even if it's just 20%, who knows, that's not the issue, have a lot of microgysts, but none of them will ever become a real GIST, and others have just one, and that's a real GIST. So I'm not sure we can really claim that one develops always from the other. It may be two different things, but actually we don't know.
I totally agree, and that's one of the reasons that I like working with Peter and John, is because I was thinking along the same lines regarding colorectal cancer, but also I think the point with microgysts is that we don't know, and it is a worthwhile thing to look into, to try and understand that development process more. So I totally agree.
Could I ask, Dr. Trent, you have a lot of experience with the inherited form of GIST. Does the mutational spectrum of KIT, is there enough evidence what the mutational distribution of mutations in inherited GISTs look like? Is it distinguishable from sporadic GISTs in terms of exon 11, exon 9, and so on? Do we have enough data?
It's similar mutations as we see in sporadic GIST. I'm not aware of any exon 9 families. There is at least one PDGF receptor family and multiple different KIT families. And then SDH also, don't forget.
I fully agree, but I would not exclude that there may be an exon 9 family around or will be at some time, because Robin already alluded to that. The event I was mentioning just takes place in in the either ovary or in the testis cells, and then it's distributed everywhere. But the event is the same. It's just the question in which cell it does happen, and whether it's passed through the family lines or not. But the event per se is not different. So we do see the same mutations as we do see in a sporadic GIST. And therefore, I agree, I'm also not aware of an exon 9 family, but I would not argue that exon 9 cannot be hereditary. It's just much less frequent and therefore has not yet occurred. But the number of families, I'm following a small number of families in Germany, maybe the majority of families in Germany, maybe half of them, and the other half will be followed by Sepp Bauer. And they are exon 11, but it's the most frequent. So it's, I would say, as expected to happen also in the hereditaries. So the answer to your question is it's the same. It just happens in different cells.
We can move on to the next, or?
Touch briefly on the last two questions
Okay.
about the correlation between specific gene mutations and the severity or the course of the disease.
Oh, I'm sorry.
Okay,
Mark.
sorry, no. So maybe the two last questions about the correlation between the specific gene mutations and the malignancy, the severity of the disease, and the last issue about the relationship between GIST and other sarcomas.
Well, correlation, absolutely clear. That has been studied extensively, and we do know that the different mutations carry a completely different biological behavior, completely different response or not response at all to the various drugs we have. So we could discuss along here, but the simple answer is clearly yes, absolutely. There is a very, very high and very well-known correlation. And the last one, the short line, is absolutely no.
I would just add that on the last one, we did look at a series of about 1,000 GIST patients about 10 years ago from our practice. And there was not an association with sarcoma, but there was an association with other cancer types. About 17% of the individuals had another cancer, excluding cervical carcinoma, basal cell, squamous cell, excluding those common ones, but about 17% had a real second malignancy, lung cancer, colorectal cancer, there was prostate, melanoma, renal. And so we generally are very, we're very imperative that patients continue their general checkups, colonoscopies. And if we ever see a lesion on so we do chest x-rays when patients have GIST, whether it's metastatic or adjuvant, we do chest x-rays. And it's not unheard of to find a nodule, biopsy it, and it's a primary lung cancer, or it's a metastasis from an occult renal cell. So chest x-rays are cheap, very low amount of radiation. So because of that study, we do the chest x-rays. And so there is an association with, in fact, 4% of patients, GIST patients, had 3 or more cancers, primary cancers, different types of cancers. So there is some predisposition. We tried to look with Jason Siklik at some etiological causes in germline, but never really found anything that panned out. It may be that there's a lot of different things that predispose, or something that we didn't have the technology to detect at the time. And then I would just say one other thing is, and it may be controversial whether it's a sarcoma or not, but there is, and the association may be more related to surgery or trauma, but we do see the desmoid tumor, we do see the association with GIST and desmoid tumor. Whether it's the GIST or some other predisposition, we don't know. It could be the fact that the patient had surgery, because we know surgery is a risk factor for developing a desmoid tumor, but also any other types of trauma. So we call it Dumont syndrome over after the GIST and desmoid combination, after the postdoc that described it.
I think just 2 points really quickly. I agree with everything that's been said, and that the follow-up and surveillance is really important for other cancers because, of course, the treatment will be hopefully curative. So that's a really, really important point to make. And in terms of the familial patients, it's really important to work with a genetics clinic as well to ensure that everything is looked into in detail.
I would like very briefly take one of the issues John just mentioned, because I would definitely stress that is extremely important. We also do chest x-rays, and also the association with desmoid is very, very practically relevant. So if a GIST patient has a lesion that is, let's say, a little bit unexpected, it definitely needs histologic confirmation. We do see occasional patients, there is a lump growing, everything else is nicely responding, there is a lump growing, then people think, okay, focal progression. It doesn't have to be focal progression. We've seen more than one patient where the so-called focal progression was a desmoid. Completely independent from the GIST and obviously not responding to the treatment as would be expected. There may be occasional responses to imatinib, but that's far from substantial. So there needs to be histological confirmation. And 20 years ago, we did a little series with early PET diagnosis. We found a lot of hot lesions in the PET, but all of them have been something else than a GIST. So if you see something in the lung, it's 99% not the GIST, but it's something else. And again, you should never say, okay, now there are also lung metastases in a GIST. We have to change therapy. You have to take a biopsy or take it out depending on the circumstances and have to confirm. And majority is not GIST, it's a lung cancer detected very early, curative surgery, don't bother any longer, but that's extremely important. So that has to be kept in mind, but it's not a relation between other sarcoma types, apart from if we call it sarcoma desmoid.
Absolutely. I totally agree, Peter. I just wonder if Marco has any comments online. So, are you there, Marco?
Yeah, I'm here. I can hear you. So yeah, it was very interesting to see how things got into detail so much regarding the causes that may trigger GIST and what causes a micro-GIST, which, as you already mentioned, can be found incidentally, virtually in up to the 30% of patients to develop into a malignant GIST. We still don't have the answer for that, but I think that the most intriguing thing when we look at GIST is knowing and always keeping in our minds what we achieved so far. So it's one of the first cancers that laid down the ground for a real translational approach. So we found KIT and PDGFR mutations and switched the therapy from standard chemotherapy to imatinib, and this caused a huge benefit for our patients. And as long as we keep that in mind and we know how far we've gone so far, we can always look forward and look for other answers and to deepen our knowledge in this rare field. But I think
we've done very well in handling question 1. We have only about another 99 questions to go.
Yeah. Can I just add a very important question, maybe with a short answer, because when we talk about the causes of GIST, very often we have the conversation with patients whether they have the idea that they have done something wrong in their life to become GIST, because they got GIST. So, for example, we have had a patient and he told us he has had a very serious time in his life. He lost his job, he lost his wife, and he knew exactly that with all these psychological issues, he got GIST. So is there a correlation? Because we know that it is, but we also want to discuss this with the experts very briefly.
My very brief answer is absolutely no.
That is important. For patients, it's very important.
Yeah, but you're right. That occurs every now and then, and I mean that's a very human issue to try to explain things. Why did this happen to me now? Absolutely. Why did it happen to him or her 2 years ago? And things like that. The answer is we simply do not know. Why does a plane crash and another one not? I mean, we may find technical issues or so, but still the question is why did this technical issue happen in this plane and not in the other plane?
I agree. So
Okay.
we
Okay, then let's switch to the next group of questions, but I think we already touched this. I think we can handle this very fast. So maybe a final comment to this?
I could just, I could just say that in addition to the hereditary KIT and PDGFR we discussed, there's also neurofibromatosis, there's SDH, and which is the Carney syndrome and the Carney-Stratakis triad and dyad, and there's something else, it seems like. Maybe that's it. Those are the common ones anyway that we see.
Okay, but maybe to show the relation, how much percent of the GIST cases are we talking about the inheritance? Because sometimes that's always a question coming from patient, whether this is possible that my children can have it or something like this. So what is the percentage when we talk about hereditary?
Couple of zeros after the comma.
Okay, okay,
It's
not very
minute.
important, not very
way of
common. So,
putting it, actually, yeah.
okay.
And so the most of the hereditary GIST syndromes are fairly clear that it's hereditary, not necessarily with the SDH, but the germline KIT mutations are autosomal dominant. So in any family that has that mutation, whoever has the mutation, there's 100% certainty that if they live long enough, they're going to get a GIST. And it's autosomal dominant, so half the people in the family have GIST. So in this large family, one of these families I follow, there's 15 GIST patients. So if it's hereditary, it's usually fairly obvious. If it's not clear, if there's not like multiple people with GIST in the family, then it's not hereditary, and don't worry about it. Other than the NF1 and SDH, which are a little different.
Which brings up one issue not to be clarified or finalized today, but something like a task to take home. When I was thinking about how to follow up my GIST family members with either GIST or, as John said, 100% lifetime risk, and you go to the literature, it's completely, I mean, there is no full consensus on what is the ideal follow-up for these patients. Some recommend, well, we should do a PET every half year or so, which is completely crazy to even think about. And others, as we do, we recommend MRI, of course, because, I mean, some of the family members, they are kids of 3, 4, 5 years. Would you put them in a PET for a lifetime every half year? They will develop guaranteed another cancer and die from that, very likely.
That's a very important point, Peter.
So
the radiation exposure with the whole body.
So we should
fatigue.
come up with a recommendation through whatever group, SPAN or whatever, CETOS, or could be anything, but we should come up with a consensus recommendation because there are a lot of suggestions. There is no proof, will never be, but we have to come up with a recommendation because that's also an insurance issue. People argue, well, my insurance will not pay for the MRI because there is no proof that I do need an MRI once a year. They may pay every 5 years and things like that. So we do need a consensus, not today, but it just, since we're discussing hereditary, that is something we should sit together and finalize.
I think that's really, really important. And the genetics doctors that I work with, we developed in conjunction with the radiology department, a whole body MRI protocol so that everything is standardized. And just to say, I totally agree regarding PET-CT. I mean, that's such a huge radiation exposure.
I just have one provocative.
I thought that was my job.
That was yesterday. So this has come up a couple of times, and conceptually that I have some patients that I follow and screen them for GIST. They don't have GIST, but they have the hereditary mutation, and they know with 100% certainty that if they live long enough, they're going to get a GIST, and it could be malignant. It could present with metastatic. So the concept has come up that we've discussed internally a few times, have never done it, but why not chemo prevention?
Yeah. Well,
If I was that patient, I would think about it. I might not do it, but I think I'd think about it.
I would probably say no. But that's actually a very difficult question. I'm just advising or following a patient from a family, and he has 2 small children. I'm not sure, something like 3, 4, 5, 6 or so. And the question is, should they now start their screening? And you know, kids in that age doing an MRI sometimes require general anesthesia. You cannot just put a small kid in MRI. That's very loud and it's very narrow. So kids don't like it. Adults may also not like it, but they understand it a little bit better, mostly. So I told them I would not examine the kids at that age. I would wait until they reach a given time. It's not really well defined. I suggested wait until they are something like 16, then discuss it with your kids, because not necessarily they do want to do it. If somebody says, well, there might be a risk, but I don't want to know about it. If it happens, it happens. That would never be our recommendation, but this is something the patient has at least to think about, whether he or she wants to know and what the consequences might be, because these GIST may be multifocal. So the patient itself, he has numerous GIST in his GI tract, no way of ever removing them. So what to do? And if you detect multiple multiple small GIST in a 7-year-old, what do you do? So this has to be discussed, and therefore we need a consensus strategy. I think we all do it right in a way, maybe a little bit different, but I would never say your strategy is wrong and mine is right and yours will become right sometime. We don't know. But these families may talk to each other. So if we come up with everybody has another recommendation, that's difficult. So we need to have a consensus. So, yeah.
That's an interesting.
Yeah, that's why I told them.
Could probably be in the 30s.
Yes, the likelihood that your small kids, 5, 6 years old, will develop a kid in the next many, many years is not zero, but not far from zero. So they should not undergo. But then when do we start? 30, 35, 50? That's all not known. And since it's not known, it would be most welcome to have a broad, hopefully global consensus how to handle these families.
Agreed. I think that's
Shall we switch over to the just to, because we also should.
Do you have a timer?
No, but maybe in between we should have a break, maybe 10, 15 minutes, because otherwise we are moving too long. So the next area is about, and we already talked about this yesterday, it's about the ctDNA. I think we don't have to go about all the details. The question is, maybe we can just discuss what is the current status of ctDNA. Is it more now driven or used by research, or is it now something that is on a routinely basis coming into clinic? I think that's the most important question in the moment.
I don't see Cesar, but number one is no. Oh, Cesar? Okay, number one, feel free to chime in. He might need a microphone, but number one is no, it's not really sensitive post-op. As of today's standard, the standard ctDNA. And then can the technology be improved? Absolutely. We all want that to be improved. Liquid biopsy used for tumor monitoring. Again, I think it's a sensitivity issue. It may not be ready for prime time yet. There may be some experimental liquid biopsies that can detect progression before radiographic progression or recurrence after surgery before radiographic recurrence, but I'm not aware that the technology in GIST is sensitive enough for that. And then the last question is early detection. And again, there's a lot of research going into it, Cesar's lab and a lot of other people and other cancer types, but the standard tests that we use in our clinic are not sensitive enough for most of these reasons.
I totally agree. I mean, that's the really sort of concise summary to all of this. There's nothing.
Any comments?
So basically what you were saying, the main setting for ctDNA testing will be advanced disease, try to identify secondary mutations that may help to guide treatment for the patients. Here we will encounter a few issues that we should be aware. First is how is the regulation of the drugs? Is basically I think you saw yesterday that there will be this trial, the INSIGHT trial, with ripretinib and sunitinib in the second line treatment when the data is super clear, right? If there is no such trial, we won't be able to treat a patient with a different line in a second, third line, right? At least in Europe. And most probably at least only in the US, maybe the edge to do that, but not in the rest of the world, perhaps.
As we discussed yesterday, and following on from the point regarding mutational testing, particularly in the United States, that trial in many ways will be very useful in terms of education and highlighting the importance of mutational testing in general as a principle to community oncologists, I think.
Maybe the simple baseline ctDNA testing in routine, not yet.
But I think it's a good message to know that research is going on, that a lot of research is going on in this area, and I think that's
absolutely.
that's a
I mean,
strong
some
message.
of the main players in this business are sitting in the room, and we are expecting major improvement, probably not in decades, but in weeks or months.
No pressure.
No, that's really an evolving business. We are conducting a study in Germany looking at remaining ctDNA after hopefully curative surgery, because, I mean, simply, it sounds very logic. There is ctDNA circulating because the patient has a big GIST in the stomach. The surgeon removes the GIST, you wait a couple days or weeks until everything is cleared. If there is still something there, then obviously the patient has remaining GIST cells in the body and would then require adjuvant therapy. If there is no more ctDNA, the idea might be, well, everything is removed, the surgeon has done it completely right, no indication for adjuvant therapy. That's a nice idea, not only in GIST, in many other diseases as well, but that is a question for the future, not yet. But patients do ask this increasingly frequent, and that's why I try to use a very simple answer, because currently, again, that is not a standard of care issue.
And here I think it's very important the technology that is used, because it's like NGS testing, that sometimes you have an NGS testing somewhere in the world and the result in the US, right? You have this CLI CLIA labs that are verified or certified labs in Europe as well, but some people just run their homemade tests and that they don't have any validation at all, and probably all of us that have received some patients with not only GIST, but sarcoma patients that come from weird NGS test result from somewhere, any institution that we cannot validate. So that means a lot of validation. Here we are talking about changing treatments, having new treatments that can be toxic and not effective, or the other way around. We can give treatments that can be highly effective. So the technology and the good technology and a validated technology is important. Here will come another debate: will we run everything by companies, or academia can do something in the field? That will be another debate. But again, that's nothing that is not a standard yet, and I hope in the next future it will.
Good. So we switch over to the next topic, and maybe this is also an area where our friend Marco also can or want to contribute, and this is the area of staging or risk assessment. Why isn't the staging of GIST tumors consistent between oncologists? Good question.
I would argue that it's probably not inconsistent between experts, and why some doctors do very strange things in diseases they don't understand at all. That is a general question, probably not to be discussed today. But I think within experts, there is no inconsensus. Some prefer CT, others prefer MRI. We do it in a way age dependent. I mean, if the patient is quite old and maybe hesitant to undergo an MRI, CT is fine. Both techniques have their advantages and disadvantages. If the patient is quite young, I would definitely convince him or her that we use MRI instead of CT, but I don't think there is a lot of discrepancies. As John already pointed out, doing a chest X-ray, that is not GIST staging, that is checking for other cancers or maybe even other diseases, but I would not see a inconsistency between GIST experienced oncologists.
I agree, and I think the ESMO and the NCCN guidelines allow a bit of flexibility in that respect, but I see it more as flexibility, as Peter mentioned, tailored to an individual person rather than not being consistent.
I just add the most useless is a non-contrast CT.
No.
Not helpful at all.
No.
Okay, so next question is, a few years ago, there was a research project in France, I think. It was the SINGSARC project. What was his name? Frédéric Chemont, I think. Yeah, SINGSARC, Frédéric Chemont? Yeah, okay, I remember right. So he has clearly shown that there is only low or high risk of recurrence. Why was this not pursued or incorporated into the diagnostics? Isn't that much better, more precise than relying on some nice risk models, including manual counting of mitotics or mitosis by pathologists? So.
I suppose in a way, I really like this question because it revolves around initial research and then pursuing something to confirm it with, a larger validation series to definitively prove the case. I think this ties in with funding and the appeal of a proposal to funding authorities, and that it can be challenging to get funding for rare cancers. And the other thing is, even though the simple techniques such as mitotic count, etc., may seem imprecise, but in experienced hands, they're well used, and in a way have been validated in larger series. So I think it's using something that's inexpensive. People are really familiar with it, and it has been validated. Whereas I think the SINSARC signature requires validation in a larger series. And to do a study like that, you need independent funding.
Absolutely.
Yeah. And it's something that pathologists are so familiar with, and it's validated.
So it's all, as I understand this right, so the complexity and also the costs of this kind of procedure is so high, and also the complexity is so high that it's quite very hard to bring it in routine diagnostics.
And I suppose, in a way, again, coming back to the question regarding reimbursement, you'd need certainly in certain countries, you need a study to say, well, this is clearly so much better than the cheaper techniques that we already have in place.
Okay.
And funding a study like that is pretty tough, to be honest with you. Yeah.
Two very brief comments. First, there are a couple of issues with the SynSarc signature also in soft tissue sarcoma. It somehow correlates with G1 and not with G3, so really opposing to what we believe to be risk factors in localized soft tissue sarcoma. So it's far from being consistent, and it would have to be evaluated in a prospective way. Second brief answer is, I don't think that this is a major issue. Risk classification is, I think, well enough to define to not really pose a problem. And what the individual decision is another point anyway. So if you come up with a 37% risk, would this justify adjuvant therapy, yes or no? That is another question. But I think we have good instruments to come up with a risk assessment. So that's not something where we are in desperate need for a new technique to try to figure out who is at risk and who not.
And I think if we were to suggest a prospective study to compare SynSarc to standard risk assessment models, and we put that forward to a funding body, that's the first thing the referee's going to say. This is expensive, and you've already got adequate. What additional benefit is this going to provide? Yeah.
Marcus, we have Marco. He would also like to comment on the staging issue.
Okay, good.
Yes. Just briefly, I do completely agree with what Peter said, and he's sort of recalling what David said at the beginning. So I don't think that currently there's any inconsistency in between what we as experts do routinely. Then everyone has got to tailor the recommendation on the single patient he's got in front of him, but it's not an inconsistent behavior on staging and risk assessment. And the second point I wanted to underline regarding the mitotic count done resembles the same exact principle. So an expert pathologist can give you a very detailed mitotic count. He can repeat it. He can do another slice on the histology, on the material that he's got from the biopsy, and reach a very accurate risk assessment on the tumor. While if this is not done in a reference center, and sadly we see this very often in our daily practice. So patients are referred from outside centers somewhere in the rural area where they've taken out the GIST, and they come to you 3 years after with wide peritoneal spread of the disease, and you ask, have you ever done a therapy or even a mutation analysis? That David pointed this out at the beginning of the talk. Is very interesting to see how mutational analysis for GIST are not routinely done in every single hospital. And I don't know how it works in your countries, but in Italy this happens very often, sadly. And this is something that we have to sort of homologate our national systems to.
perfect, but a new model would have to really be so much better in terms of predicting to justify that process of validating such a model.
You know, where the SynSarc might help out is in the intermediate group. We know that the high-risk group needs imatinib. We know the low risk doesn't. There's going to be some people, and we see them in clinic, with intermediate risk. But we're a little uneasy because the mitotic rate is pretty high, but not quite over the border. It's a small intestine tumor. And so separating out the intermediate group into low risk and high risk might be helpful use of SynSarc or some other modeling.
Okay. I think the last two questions are the same question, more or less. It's about the mutational status within the risk classification. Currently, we don't have the mutation within the classic risk classification.
That's one of my standard questions to our pathology friends, because for years now, they claim that they are about to publish the new classification system, including mutational status. At least that's what Eva Wadelmann tells me for 5+ years now, or Paulo Deitos. So it could be possible, it would be possible, it should be done, but it has not yet been done. But I think all of us will still do it. If I have to decide on adjuvant therapy, yes or no, the mutational status is included in my personal risk assessment. It's not something you check out in a table, but it's something you do. So you check out the risk, you look at the mutation, and then you come up with a recommendation. And I think we all would do that.
I totally agree.
So it's basically, it's integrated, yes, but not in a standardized manner, but in an expert decision manner.
Okay.
And this actually goes back to
We
what
have a
previously.
Ishi, can we have a mic for Ramesh? Thank you.
Thanks very much for the lively discussion. I think we got a bit, I won't say complacent, but we got a bit very much used to the Meitner and Lasota stratification back in 2006 and the modified AFib about 6 years later. What I have been doing in real life is use the maintenance or modified AFib for simple, straightforward, low risk or high risk. Intermediate risk, try to use the Hakes prognostic contour maps. They're very, very useful in defining that, looking at the number of mitoses and trying to work out where the patient fits in. And then more recent, in the last 3 or 4 years now, I started using the mutational status data information. Does the patient have a deletion, substitution, point mutation, and where is the mutation in exon 11, for example? And we were talking about this last night, about 557, 558 deletion. The moment I see 557, 558 deletion, not the release insertion, but just the deletion, I try to personally, in my own field, I would put the patient at a higher risk than what the maintenance or the AFib or the prognostic contour map says. The unfortunate thing is we haven't actually got enough large data set to actually incorporate and validate this into a recommendation in any of the guidelines, whether NCCN or ESMO or UK guidelines. But some of us are already using this information in that gray area, intermediate risk area, where we are actually trying to push the patient into adjuvant imatinib. But it's not standard of care.
And again, it comes down to reimbursement in a way in certain countries, and
Yes.
yeah.
I think the way if you look at where the adjuvant imatinib is licensed is deemed to be at high risk, then it is up to us to define what that high risk means. Would you accept a 24% risk of relapse high risk? Whereas in the table we have, that is categorized as intermediate risk. But if you go to breast cancer patients or lung cancer patients, 24% of risk of relapsing would be considered as high risk. Whereas we don't. We actually say 24% is intermediate risk. So that's one of the things where I feel that we got because imatinib works so wonderfully well in the metastatic setting, perhaps as oncologists, we become a bit kind of relaxed about the risk stratification in the sense that we don't worry about it. But if the systemic therapy is in the metastatic setting very poor, or if there's no systemic therapy, then we'll be much more active and much more careful in defining the risk.
Yeah, that's a great point, actually. In comparison to other more common cancers, you make a really, really good point.
But the main issue here comparing this decision to breast cancer is that they are based on numbers and clinical trials with 10, 15, 20,000 patients. We do know that, for example, a risk of 4% can be brought down to 2% by doing this or that over these many months or years. That is well studied. The question in GIST is, in a way, much more complex or much simpler, because whatever the risk is, the only question for us is, does it justify adjuvant therapy, yes or no? And whether the risk is 15, 17, 35 or 52, that may be interesting for the patient or the physician, and the follow-up may be a little bit different for these different issues. But the question remains, do we have data justifying adjuvant therapy in this specific situation, yes and no? And this has become even more complex. We will move to this question in the next slide, but based on our new publication on the SSG18 study, things have become even more difficult in decision-making in adjuvant therapy. So defining the risk is not really the issue. What to recommend is the issue. And we will come to this in a minute.
Yeah, I agree 100% with Peter. The first question is, do we recommend adjuvant therapy? And then the second question is, what is the probability of adjuvant therapy helping the patient? And that has more to do with the mutation status than the risk,
Correct.
I think.
Good. Maybe just, this is an ideal switch over to the next topic. We just talked about adjuvant treatment. Just before we switch over, Michi, can we just prepare coffee outside so that we can have a break maybe in 10 minutes or something like this? That would be good.
That's prepared already.
Thank you. Okay, so the next topic is the long-term adjuvant treatment or adjuvant treatment.
I should say this was a question that came up from many people.
I can imagine.
Yeah, but we have to make clear, bullet point 1 is not associated with the discussion of adjuvant therapy. That is completely different. That is a general misunderstanding. Patients on long-term imatinib that has been started because of metastatic disease, whether stopping yes or no, and when, and what is the remaining risk, that is a completely different issue. It's misplaced here on slide A5 because it's not an adjuvant question. We do have answers for 1, 3 and 5 years. The French will do another randomization after 10 years. We have a number of small data sets also from Scandinavia. And I think the bottom line at the moment is the recommendation is to never stop, but there may be a subgroup of patients where the risk or the possibility of stopping may be around 50%. So you need to discuss with your patient. When there are limiting toxicities, then we do every now and then recommend to stop. I mean, if the patient has very difficult kidney function and is facing dialysis, I would rather stop. But there are no data here, but that's not an A5 question.
Yeah, agreed. So that's a careful discussion with the individual, isn't it, basically?
I would just say a couple words about the last 2 bullets. So there's not a lot of good data on the second to last bullet, but there are, you could justify using a higher dose of imatinib for adjuvant exon 9 based on the metastatic data. So it's not unreasonable to push the dose a little bit higher. We do it practically. We do the highest dose the patient tolerates up to 800 with a good quality of life, because adjuvant setting, quality of life is very, very important. But then for sunitinib, I really don't think, I've never done that. I don't think that I would recommend that. And
There are no data.
there's
to
no
support
data at all.
That's
So there's a consensus.
It's to be honest, it's one of my favorite questions, this, because it's absolutely controversial. And we have had so many very lively discussions with very close friends and experts where we could not really find an agreement. But if we take a couple seconds, what are the available data for dosing in exon 9? In metastatic GIST, the data set is very clear that 800 milligrams is superior with respect to all endpoints. So that is, from my understanding, a more than excellent justification to use this dose also in the adjuvant setting. That is number one. So if we look at the data, we have basically two data sets. From the early data, to my knowledge, never been updated with long-term experience. In the first ACOSOC study, no imatinib or 1 year of imatinib, there was absolutely no difference for the exon 9 subgroup. That would mean, with all limitations in numbers and missing long-term follow-up, that 1 year of 400 milligram in exon 9 is not better than 0 days of imatinib, 400 milligram in exon 9. Even more important, and what makes me, we have 3 data sets, sorry. What makes me very, very strong in my personal recommendation, we have just a couple of weeks ago published the outcome correlation with the mutational status in the SSG18 study. That's the 400 patient study comparing 1 year to 3 years. And the very, very clear data do show that when you use 400 milligrams of imatinib in exon 9, there is no difference between 3 years and 1 year. And if you then take the ACOSOC data that 1 year is not better than 0 years, the conclusion is in logic, also including the metastatic data, that 400 milligrams is of absolutely no use in the adjuvant treatment. So whether you use 400 milligram or 0 milligram is not proven to be any different. That's the current status of available data in exon 9. Now, even more conflicting is the series published by Bruno Vincenzi with all our data. So we have contributed to the publication. To be honest, I expected a completely different result, and I think this is still very conflicting, but he came up in a retrospective series that 400 and 800 is not different, which has a couple of very, very difficult biases, and it's a retrospective series. So my bottom line is, I do not see any evidence at all to support 400 milligram in exon 9 in an adjuvant indication. I do see a lack of really supporting data for 800, but this has never been prospectively studied. Given our own personal experience with patients recurring on 400 and responding to 800 once the metastases have been detected, and all the experience in the metastatic disease, my personal recommendation is, as John just said, I do recommend 800 or whatever the highest tolerable dose may be. I do not see a rationale to use 400. Very likely you could then use 0. That is the current data set. Nothing else is available. So I do say highest possible dose or nothing. No justification for 400. Not at all.
That was brilliant. Very, very nice logic there. I think that's very well laid out and supports what I think most of us are doing. Now, I would just ask another question. What if the patient has a mitotic rate of 20 centimeters, small intestine GIST, it's resected, and there's a RAF mutation or a TREC mutation? Would you recommend adjuvant therapy in that setting? Because there's much less data even than exon 9.
So
If you could get it, let's say you could get it.
that would really, as you say, John, there's limited, really no evidence to support that. I would certainly discuss it with somebody, but I think at the end of the day, there's very limited evidence to justify the use of adjuvant therapy in that setting. But it requires a careful discussion.
I'll pay for it.
Well, I mean,
Any data, but the risk is there.
well, there's a big risk in a way, even though
John, that's really a very, very,
philosophical question. It's
very nasty trap. So I would then like to use my usual reply to such a trap. How long would be your treatment recommendation?
Well, again, I think it would have to do with the risk. And if it's a standard high risk patient, I would do 3 years with current data. I think for me, a more difficult question philosophically is the D842V patient. A lot of times they're not high risk, but if they were high risk, it's a risky drug to take too, that you can really harm somebody.
I think there's absolutely no evidence there for adjuvant therapy. And in the localized disease setting, that molecular subtype can very often be quite indolent. So I would not advocate the use of adjuvant therapy in that setting. Yeah.
Okay. So maybe we should now have a short break. Maybe
For the next trap question.
the next trap question, yeah. We have another 5 slides. So thank you very much for the first part, for your expertise and for your discussion. So it was extremely helpful to follow this. So thank you very much. And we will continue in, I think, round about 10 minutes. So just having a bio break, grabbing a coffee, and then we just continue. And thank you, Marco, for your contribution. So you have a wonderful Italian coffee now in Italy. So, okay.
I will take my coffee here if you don't mind.
buon anno a tutti.
Ecco, questo è quanto. Tenete conto che questo stesso scopo può essere perseguito non solo. Ora, è molto brevemente, nella malattia metastatica invece la chirurgia non è uno standard, d'accordo? Il vero standard è la terapia medica, che è provato a immaginare di operare i pazienti dopo trattamenti ultimati per cercare di prevenire situazioni, per cercare di prevenire il tumore, cercare di prolungare il tempo alla progressione, addirittura curare i pazienti, ma non siamo mai riusciti a ottenere un'evidenza. Quello che sappiamo il risultato della chirurgia in fase metastatica è poi cioè i pazienti ma malissimo. E questa situazione intermedia deve essere focale, tra la quale c'è un interesse. Tenete conto comunque che la chirurgia rischio di fare dei di Boston è stato con una comorbidità che debba togliere una lesione di 10 alto rischio la risposta infatti non siamo legati da programmare compresi non sono stati che va a accadere nella malattia non c'è nessuna indicazione, nella malattia con progressione isolata questa può essere. Come definiamo la progressione isolata? Conosciamo tutti questo tipo di progressione che abbiamo iniziato a descrivere con la immaginare di
So we need to get our panelists back. They are lost somewhere. So where's the boy group? Please, boy group, back on the stage.
Oh, we can start off with Marco.
Yeah, I think that's a good idea this time.
Yeah.
Where's our German boy for the boy group?
The front man.
The front.
Like I looked for Peter. We can start with Marco though.
Yeah. So is Marco back online? Not? Okay.
I'm happy to comment if we have enough people here. Whenever you're ready.
He's lost. Okay.
I can comment to number one.
Okay.
We don't have Marco.
So, is Marco back? No? Okay. So maybe we can start with Jonathan and then hand over to Marco.
So the question is about the role of surgery in metastatic disease, and there's actually some evidence on it. It's retrospective. The prospective trials never really panned out due to lack of accrual, but there's some data on retrospective studies, and so with imatinib and also with sunitinib. And so the data is such that patients who have progressing multifocal metastatic disease don't really seem to benefit from surgical resection of the metastatic disease. However, if there's a patient that has metastatic disease that is now responding to a tyrosine kinase inhibitor, those patients do seem to benefit from resection of those metastatic sites if they can all be resected. If they can't all be resected, some can be resected and they're responding. There seems to be some responding or stable. There seems to be some intermediate benefit. But again, this is all retrospective data. And we know that there's a big bias there because we know that patients who are responding to TKIs are going to do better than those who are not. So there's a big bias there. But, I think that it's reasonable to discuss with the surgeon if you can remove all visible metastatic sites and that the surgical morbidity is not it's not an overly morbid surgery for the patient, because the quality of life in this situation is also very important.
I agree. I think, that as John has pointed out, the major caveat is that the studies are all retrospective and that there's an inherent bias. I think surgery, if there's low morbidity, if it's feasible, if there's a solitary area of progression, if there's a tumor in a tricky or an anatomic position that could cause problems if it progressed, then we would consider surgery. Sometimes I have the sort of discussion regarding just carrying on with imatinib rather than sort of resecting all of the residual disease. And as John said, it's a question of sort of weighing it up with the individual patient. But I think the bottom line is that surgery, in certain circumstances, in people with metastatic disease, does have a very useful role. But the evidence base is very limited.
Okay, I think Marco is back online, so maybe we can have his statement or his opinion on this.
Sure. When it comes to the surgery in the metastatic setting of disease, it needs to be very carefully discussed with the patient, because even more tailored treatment than in every other setting of disease. We tend to propose surgery for focal progression now in my institution. It's a usual thing. But it also needs to be very carefully evaluated on an individual basis. So as John said before, the assessment of how morbid the operation we're going to do plays a crucial role, in my opinion, regarding the final decision. Of course, the evidence are all sort of limited and biased by the nature of the studies that have been done, which are mainly retrospective series. But still, we do see an advantage of taking a progressive nodule within a metastatic setting to delay the switch to a second-line treatment or to prolong the response to the current line of treatment. Then the other thing that must be taken into account is that we tend to now propose minimally invasive surgery for localized disease, basically in every single district, so going from the stomach to the rectum to the small bowel, and this is almost feasible in our casuistic here in Milan to an 80% of patients, which we're trying to treat with minimally invasive procedures for localized GIST. But in the metastatic setting, this is not always feasible. So also this must be taken into account regarding the quality of life of our patients. There's a crucial paper for that done by Mark Fairwater that identified the main determinants of the expected morbidity after surgery. And this, I think, is a crucial point that needs to be discussed with the patient. I don't know if you do agree, and what are your usual questions to your surgeons in your institution regarding surgery in the metastatic setting?
Maybe I've missed something in the first couple minutes on this slide, but I think we have to come up with two very basic general conclusions. One is that I think we are all convinced that there is a role for surgery in metastatic GIST, and it has to be carefully evaluated on an individual basis, including the surgeon or local therapist, maybe an interventional radiologist and the medical oncologist, and also the patient. So that's, I think, completely agreeable, even if we do not have a very exact definition what the criteria are for the patient. The second issue is that we definitely need to prevent unnecessary and completely useless surgery, and that is the biggest problem. Not infrequently, we are confronted with patients asking for advice. And the classical issue is they have numerous liver metastases, but they found a surgeon who says, well, 2 or 3 I ideally located for surgery. So I take these 3 out and leave behind the remaining 25, 30, 100, whatsoever. That's the classical issue. And unfortunately, many of these patients, if they are not experienced enough, or if they don't ask an expert for second opinion, or maybe third or whatever opinion, there is a high risk that they undergo this completely useless type of surgery. Because, and that's something I also used to argue, there is unfortunately nothing like an off-label surgery. If we medical oncologists with differences across the globe, then we can only use drugs that are approved because there have been studies, data, support, and so on to use a specific drug in a specific situation. Otherwise, it's off-label and will not really paid. There is not some such thing as off-label surgery. In such a situation, surgery is completely useless and it should definitely not be paid, but it will be paid. Yeah, and that is the problem, to prevent this and to try to tell the patients, because some patients, they still do it. Well, then it's 3 less.
I think that's a really good point. And one of my surgical colleagues, Andy Hayes, his comment is always, well, the question isn't, can you do an operation? You can always do an operation, but the question is, how is the operation going to help that person? And I think that's essentially the crux of this. In what way is the operation going to help in terms of the overall management of a systemic disease, rather than the question of, can an operation be done? Because it's always possible to do some form of operation.
Yeah, in these cases, I recommend cholecystectomy or something like that. Because if a patient really wants surgery, I'll tell them, well, you could discuss a cholecystectomy instead if you really want to have some sort of surgery. No, just kidding. But as you said, there's always something you can take out. But the question is whether it makes sense or not. And especially in the field of GIST, my experience is the better the surgeon is, the less surgery he or she will do. Because the less experienced, they will do something, mostly completely useless. And that is another important issue. Even if we argue it's useless, some patients say, well, but at least it doesn't harm. That is absolutely not correct. There may be substantial harm, and we have seen so many cases where this type of surgery had an obvious impact on the biological behavior of the disease. This is a phenomenon we do see in many different types of cancers. It has not really yet completely clarified what exactly is happening, but the cause is somewhat indolent, and you think, okay, we take out a little bit, and then it's really going off.
And one of the worst complications I've seen in this situation is when a surgeon does a very aggressive yet unnecessary surgery, and then the patient has limited capability to take oral medications. And if you can't take oral medications or absorb oral medications with GIST, it's a big, big problem.
So as I say, I think the major thing is, the question is, how is the surgery going to help in terms of the overall management of a systemic disease, rather than can an operation be performed?
And how could it harm?
Well, precisely.
Okay, thank you. I think in the interest of time, we should now switch to the next topic. And this is about drug sequencing and new drugs, systemic treatments. So this is about many questions and a huge block about treatment sequencing. So maybe we can talk in general about sequencing, but also about new drugs.
Well, I think as a start, we can make a very general statement. Outside a clinical study, as of today, the sequence is clearly defined by any available international guidelines. Switching from this sequence to an individualized treatment outside a clinical study is not yet supported at all. So first line is imatinib, second is sunitinib, rego is third, and ripretinib is fourth line in the KIT sensitive mutation group of GIST cases. Avapritinib is the standard of care for D842V. A number of trials are underway. A number of trials have been done to challenge the sequence. So far have been negative. Avapritinib, regorafenib third line was negative from the perspective of avapritinib because rego was even better. So that did support the role of rego in third line. And the second line study, ripretinib versus sunitinib, was also negative for ripretinib because it was not significantly better. But it led to the subgroup analysis for a subgroup, 20% with dramatic benefit from ripretinib compared to sunitinib, and that will lead to a new study starting likely Q4 this year. The INSIGHT study comparing sunitinib versus ripretinib in a small subgroup in the second line. And this subgroup will be defined by ctDNA analysis. So that's the only example where ctDNA analysis will lead to a consequence, but in the context of a clinical study. In selected sites around the world.
50 plus sites.
Yes.
So it's international.
Yes, which is crazy. The rationale here again is, and I always argue this with the pharmaceutical companies, they think the more complex the question is, the more sites they need to activate, which is, sorry to say that, complete bullshit. Because the more complex the study is, the smaller the number of sites should be, and it doesn't make sense for a 54-patient study to open 50 sites. That is completely crazy, cost millions of dollars or euros or whatever other currency, and will not increase recruitment. That's the completely most foolish strategy you can follow for such an approach. In Germany, we will have 2 sites.
So Peter and I agree on virtually everything. Our presentations sometimes are slightly different, so that's what I'm saying.
You're talking about the usage of difficult words. Yeah, of course, you're very British, so you would never use such a word, of course. And I would obviously deny having ever used such a word.
Are we being recorded?
No, we have to talk about the recording. There was a slight technical problem for 1 or 2 minutes.
Edit.
Yes. So.
Yeah, I agree with all of that. The paradigm, imatinib, sunitinib, regorafenib is like we discussed yesterday. It's just all on the order that the trials were done. There may be biomarkers that emerge, like circulating tumor DNA, and this may come out of this concept, this paradigm, which doesn't exist today. This paradigm may be proven in the prospective INSIGHT trial. There is retrospective data suggesting that sunitinib's not a very good drug at exon 17, and rego and ripretinib are not very good at exon 13 resistance. And so from retrospective data, that seems to be emerging, but the prospective proof of it through the INSIGHT trial, and then through our circulating tumor DNA trial at Sylvester, where we're prospectively assigning therapy based on patients' resistance mutation, are the type of prospective studies that might prove this paradigm. And then just one comment quickly. Conceptually, I don't think a lot about sequencing, and I don't put patients in the space where they're thinking about, what drug's next, what's the third drug, what's the fourth drug. We try to really focus on what they're on today. How much mileage can we get out of this drug that they're on today? They're on sunitinib, regorafenib, imatinib. They get a solitary progression in the liver. what can we do to address the solitary progression and keep them on the drug that they're on to treat everything else? And so we try to get as much mileage out of every drug that the patient has available, because even with all these trials, there's still limited therapies. And we want to find the one that's working the best and get the most mileage out of it. And then also revisiting. Patients progress on sunitinib, and then they get regorafenib, they get ripretinib, they might go on a clinical trial with something. And then sunitinib is really good at exon 13. So if an exon 13 resistance mutation emerges in 6th line, rechallenging with sunitinib is also a good ploy.
I think that's a really important point regarding the use of every treatment modality to enable somebody to carry on with a particular treatment for longer. I suppose my short answer to this slide is that sequencing and combination therapy is still a work in progress, and I think we need more evidence before we can give categorical answers to any of these questions.
Absolutely. And I love this, your explanation of getting most mileage out of the treatment. We always have in Germany the same discussion. How can we get most out of the treatment so that the patient has the longest benefit from the treatment, but with an acceptable quality of life? That's what we try to do with the so-called therapy and side effect management, for example, and different issues.
That is clearly a sign, as we can imagine, of experience. Yeah. The quicker you run through the lines, the less experienced you are. And we do see patients who have gone through 3 lines within a year. They had a little bit of that, and somebody said, well, I'm a little bit disappointed. I heard this would be a wonder drug, and it's still, there's some disease left. Even after 2 weeks of treatment, we need to switch to another drug. Ooh, it's terribly tolerated. We stop it immediately. There's another one I've heard. Then they give it for another couple of weeks. That is a clear sign of complete lack of experience. So the more experience, the longer you keep your patients on a given drug, in most cases. There are situations where that does not work, where you have to stop. I mean, if there is a complete liver catastrophe with imatinib, that's 1% of patients, no way, you have to stop. But this is extremely rare. Normally, you can keep your patients quite a long time on the drug.
We call it dinosaur dosing.
Exactly.
Sorry, what was that, John?
Dinosaur dosing.
Yeah, so I think that thoughtful approach is really, really important. As you say, when somebody's referred after having gone through 3 drugs in a year or so, it's just crazy. And it's never, or very rarely, as Axel would say, an emergency to switch from imatinib to sunitinib. You've got time to think and to consider other options before actually switching a line of systemic therapy.
The other things that we do that may not be done at a lot of community, probably not done at all at community practices because they're too busy, but what we do is we go back and look at each agent. We look at patients been on 5 different treatments. We go back and look at the imaging of each agent. Because sometimes sometimes there's more of a response than they think, and sometimes the progression isn't really, exactly. We might have, they switched from sunitinib to regorafenib, but we may have given it a little more time. We may have left them on it a little longer because it was a response and the patient was enlarging because of hemorrhage into the tumor, or there was only a solitary lesion growing, really. And then they switched to regorafenib and there's 50 lesions growing. Maybe we could go back to sunitinib. So it takes a lot of time, like what Robin was saying, really to assess a complicated GIST patient who's had multiple lines of therapy. It takes a lot of time. And then I would just end by saying that there is a combination study that's ongoing. The second line, bezuclastinib plus sunitinib, is a second line prospective study that certainly looks promising, and we'll understand whether there is a benefit to combining TKIs from that study.
I have often recalled and often repeated the wise words I first heard from Dr. Reichart maybe 10 years ago, that Dr. Reichart said, when I have referred to me a patient who has undergone progression of a GIST while on therapy with imatinib, you said, I ask 3 questions. Is it GIST? Is it progression? And were they getting imatinib?
That's true. I would still say the same 10 years later. We have a question until we get a microphone to this lady. Just a brief comment with respect to bullet point 1, what John just said, the combo of bezuclastinib, sunitinib. The reason why this combo seems feasible is that this new drug has an extremely narrow window for targeting. And that means also a very limited amount of toxicity. So what we have seen for the combo data, it's not very different from the classical sunitinib toxicity. So it seems to not substantially adding. And because it's written here, it's absolutely impossible to combine imatinib and sunitinib because of massive overlapping toxicity. The same applies for sunitinib plus regorafenib. It's completely impossible to combine these drugs. So people have come up with sequential therapy, 3 days this, 4 days that. That doesn't work at all these concepts so far. So looking for drugs that are feasible for combination, bezuclastinib seems to be the first, and the data are really appealing. We will see that has a potential to change and to challenge the sequence. Because, I mean, very clearly, if this works as we hope and in a way expect, how will this affect further treatment lines? I mean, bezuclastinib is an outstanding exon 17 inhibitor. So whatever escapes sunitinib and bezuclastinib, what would you expect could be of any help in such situation? I mean, sunitinib is still the by far best in exon 13, and bezuclastinib, whether it's better or not than ripretinib in exon 17 is an open question. But again, if it just escapes these 2 drugs, what remains? So there may be no 3rd or 4th line because it's expanded. So that is a lot of open questions for the future that need to be answered.
Still a work in progress. As
Maybe just take the question.
Thanks, Marcus. I want to take us a little bit back. So, and it might sound like a really, really strange question, but I'll give you context. So in our country, if you are switching and there's generally a patient their insurance would not reimburse the second line, they'd be expected to pay, especially on sunitinib, they'd be expected to pay 80%. However, our law allows us to appeal that. So my organization runs the legal surfaces to appeal that on behalf of a patient. The timelines written into the law say that between the insurer and the doctor and the patient, because the law says the patient must run the process, that entire process can take anything from 6 to 24 months. So when you say time, I'm wanting to understand what you say you've got time and you need to take time to make those decisions, and what time frame are we looking at? Because in order to speak to that time frame, I have to do a legal submission to the authority saying that it's an urgent case and that this patient needs turnaround in X amount of time because his disease requires that. So what timeline would you look at? Obviously, it's not 24 months.
I think what we do know here is from all available clinical studies, all without exception, the progression-free survival in a progressing patient being put on placebo or no active drug or whatsoever is very few weeks, around 3 weeks. But that's a matter of how often you do imaging. If you would do imaging every day, it would be probably 7 days or 6 or 8 or 10, very short. And if a patient is rapidly progressing on a drug X and does not have a chance to switch to the next active drug, we are talking about very few months of remaining lifetime. So this patient will be dead within a couple of months, statistically. There are exceptions, of course, but statistically, waiting for a couple of months means you will never spend $1 or euro on this patient any longer because he or she will be dead.
Yeah, in fact, there's placebo data from multiple GIST trials now, and new publications emerging showing that stopping imatinib, or at least stopping imatinib is, like Peter said, is the worst thing you can do. So continuing imatinib in a progressive patient is really standard. And then there's also data that escalating imatinib, if you can do that in your country from 400 to 800, can buy a little bit more time, maybe a month or a month and a half longer, maybe even longer than that, until you can get the second line therapy. But starting that request, starting at ASAP, there's things you can control and things you can't control, but from the patient perspective and the doctor perspective, they can keep the patient on imatinib, dose escalate to 800 while we're trying to get the sunitinib. And then the other thing is judicious use of localized therapy. Maybe the largest lesion could be ablated, embolized, radiated, maybe even resected to buy time until they can get to that second line therapy, because they really need, you have to focus on getting there because it can help sometimes for years.
I totally agree.
Sorry, very briefly, but all these interventional techniques you just mentioned are by far more expensive than generic sunitinib, which is very cheap now, available everywhere. So doing an ablation to save money for generic sunitinib is again, beep, bullshit.
You're implying that the regulatory use logic, though.
No. But I would love if they would, but we all know that they don't.
I think John's point regarding continuing imatinib is really, really important. It's better than stopping. Yeah.
So,
but then again,
maybe just as a very small summary, I think one of the issues is really, as we just discussed, to get the best out of the existing treatments, really to do a good therapy and side effect management, and hopefully to do or to get these drugs in the hands of the right people, the right experts, so that really it has to do with experience and expertise. That's one part of the story. And then, as we all know, we also need new solutions. We need new trials and new drugs. And we will hear later from Cesar also about some research, ongoing research. So maybe just coming to the next topic, it's about systemic treatment, and this is also some of the topic that has been mentioned several times. It's about long-term side effects. I think this is more or less all the same topics, and it is clear that patients who are taking this drug now for 10, 15 years that they think about, or maybe they experience some long-term side effects, or they think that these are long-term side effects, so these are issues.
We definitely do see long-term side effects, but it's sometimes difficult to distinguish between a side effect of imatinib and a side effect of having become 15 years older. We do hear complaints about impaired visual function, needing glasses or more stronger glasses, but attributing this to imatinib instead of having grown older for 10 years, that is obviously very difficult. We do see some neurological issues. We do see some kidney issues. These I would clearly attribute to imatinib. That's a known side effect, and it can go as bad as hemodialysis. We have seen this in very selected patients. So it's a possible long-term side effect, but again, many are difficult. I tell the patient, well, I do hear this occasionally. I cannot exclude that it's related to imatinib, but you have to keep in mind that you are now 10 years older than before, so needing reading glasses is not something only imatinib patients do experience. So how long do you take imatinib, or myself, or you also have glasses? So just kidding. That's something we need to keep in mind when we attribute side effects to a potential treatment. But nevertheless, the bottom line is, yes, they are, and probably not completely understood and not completely quantified. I don't think we have sufficient information here, and that would be something advocacy groups could look at in a registry, asking patients, I mean, it's written here 10 years or more, what they think might be long-term side effects, and then we could get some more information here. But keep in mind, imatinib is not the only possible cause of many of these things over the years.
I agree 100%. And no, go ahead. I'm sorry.
Just, I totally agree. I mean, yeah, it is what it is.
Yeah, I think it's, for the vast majority of patients, more than 10 years, long-term side effects are minor and reversible. But there are occasional patients, like Peter mentioned, that have kidney problems. But, and again, it's rare enough, it's hard to know whether or not that's outside the normal, what would happen with aging. One that we identified years ago with sunitinib and regorafenib was uncontrolled hypertension. And now the GIST centers, we know to manage it, we know to keep it below keep the systolic. At our center, we keep it below 150 generally. But when we first started using the agents, we weren't paying that much attention to the hypertension. And there was some concerns about heart failure and cardiac problems. And so our IRB had us look at all of our patients. So we went back and looked at all of our sunitinib and regorafenib patients. And I think out of 200, we had maybe 2 or 3 or 4 that had heart failure. And maybe one of them was unrelated, ischemic heart disease, but the ones that had what we thought was sunitinib or regorafenib associated heart failure had uncontrolled hypertension, like systolics in the 180s, 190s that were not being controlled. And this was like 15 years ago. We all know a lot better to take care of that today, and we don't see heart failure anymore. I mean, it just doesn't happen because we know to control the hypertension, but I don't know what's happening in the community. It may not be as aggressively controlled, because sometimes the community oncologist might say, well, the patient's got metastatic cancer, they're not going to live very long, why even worry about the hypertension? When the reality is that patients with GIST can live for many, many, many years, and we do have to stay on top of the hypertension.
Yeah, agreed.
Okay, I think the next chart is also about side effects. It's about quality of life. And I think this is also one of the issues we already discussed. And this is very much about therapy and side effect management. How good is therapy and side effect management with a patient? That's one of the major issue. I think we talked a lot during the last years also in the community about individual dosing, flexible dosing, and all these issues. Any other issues? More research in side effects?
I mean, just to keep in mind, many of these so-called side effects are not side effects, but effects of the drug not desired. I mean, when sunitinib causes hypothyroidism, that's not a side effect. That's an effect we use with very similar drugs to treat thyroid cancer. And also the effect on hypertension. I mean, that's VEGF inhibition. We do see with any drug having VEGF inhibition. So that's again not a real side effect. It's what this type of drug does. We either want it or not. It causes whitening of the hair. It's not a real side effect. That's what this drug does. I mean, that's what it was designed for, not necessarily this effect. but it does inhibit targets, and that leads to effects. So that has to be kept in mind, and therefore it's in many situations absolutely impossible to separate effects from side effects. So we need to find a dose that is tolerable for the patient, that leaves acceptable quality of life. But for good quality of life, an essential issue is at least the disease stabilization. Good quality of life with a rapidly growing tumor is an issue, because the quality of life will be very bad within a very short time. So we need to find a balance here, but the idea, can we completely avoid the side effects and still have an active dose? The answer here is unfortunately no. So we have to find an individual way.
Yeah, exactly. It's sort of trying to, as you say, find that balance and finding the sweet spot for dose and response and managing side effects.
I think that another question for the panel. I personally think maybe with sunitinib and regorafenib, the recommended dose might be a little high.
Well, I think we discussed this a little bit yesterday regarding the regorafenib dose in particular, that everybody basically has to come down from the 160 milligram dose. So I agree, and I think you and I have spoken about this before, John, about, sometimes there are really sort of unusual schedules that we've adopted for sunitinib and regorafenib in terms of alternate day, increasing doses on different days. And it's almost tailoring it to that individual person. And there's very little, as we discussed yesterday, very little evidence to guide us, but it's just trying to find that, as I say, sweet spot in terms of the dose response and managing the side effects.
Yeah, like Peter said, we try to find the highest dose that patients can tolerate with a good quality of life. And then, we don't talk about this a lot, but the experienced GIST centers do not just in shrinking tumors do a good job, but we also do a good job in managing side effects, because we have experience. We have nurses, nurse practitioners, pharmacists. We have a whole team that sees GIST patients day in and day out and are used to these medicines. And, my nurse practitioner will meet with patients as frequently as they need to be met with if they're having side effects. And they're very good with, some working together with us and the patient at managing the side effects. So if a patient is taking an inhibitor and has a side effect, our first approach is address the side effect. And then, we do everything we can to manage the side effects. If everything that we can do, the patient has not a good quality of life, then we talk about reducing the dose or some of these creative schedules. And, I'll give you an example, and this isn't the best example right before lunch, but some patients have diarrhea, and they're managed in the community, and the community doctor or nurse says, well, after you have diarrhea, take some Imodium and see how you do. And they follow the label on the bottle, and it says, take it after each loose stool. Well, that was developed for infectious diarrhea that's going to run its course and be over in a week. And so that doesn't apply to TKIs. So what we do at GIST centers is we ask some questions. When do you have diarrhea? How often? How many times a week? How many times a day? What time of day? Well, I take my TKI and 2 hours later I have 5 loose stools. And then we say, well, take an Imodium or 2 when you take your TKI, and let's try to prevent the loose stools. And then if the Imodium doesn't work, we use Lomotil. If Lomotil doesn't work, we use tincture of opium. But we can generally control diarrhea in the majority of patients. There's very few where we can't control it when the patient's at an experienced GIST center.
Yes, I'd just like to underscore that you just heard it. I can only say amen to that it's another really important reason why we recommend people to be seen by GIST experts. Not just a question of prescribing the drug, but of being able to experience that allows you to deal with the side effects. And if you don't manage the side effects, then you're not managing the therapy. So I think that's really important take-home message. I also wanted to say there's an aphorism in the drug development business that there are 30,000 human proteins. And so when you're designing a drug to specifically inhibit one, there are 29,999 possible side effects. So you just have to deal with them. You can't expect that you can't expect there will be a drug without side effects, as we just said. And many of these TKIs, in a sense, they're not even side effects. They're effects, but for different indications.
But coming to practice, we are back, as we already discussed, with our topic of therapy and side effect management. You need to have a good therapy and side effect management. This is done in many GIST centers because they are used to, they have the experience. Sometimes, and this is becoming more and more problematic also in German hospitals, that they don't have the resources to do it, unfortunately, because lack of nurses and all these issues. It's becoming more and more problematic, but sometimes it's also a question of mindset, whether I'm, as a doctor or as a team, I really follow up the whole therapy and side effect management, whether I'm able or not, because sometimes, and we have discussed this very often, the drugs are simply prescribed and then the patient is sent home and the patient is more or less alone with his side effects because no one is there. And then the patient logically is going to his or her dermatologist, to his or her cardiologist, and very often these guys are overwhelmed with this situation. They can't keep up with the situation. And then let me ask a provocative question to the whole setting. What is the incentive of a doctor, of a medical team, to maintain an oral treatment? If there is no incentive in the healthcare system to do this in a proper way, to maintain the situation of the patient, to take care of the patient, and this is not a question of ethics or philosophy, very often, unfortunately, it's a question of resources.
Absolutely. Sorry to...
No, it's good.
But you address...
say the same thing, Peter, just in a different way, I think. Yes.
You address Germany. It's probably not very different in other countries as well. But as you mentioned, the problem is there is absolutely no incentive. If I do spend an hour with a patient explaining and dealing with side effects, I mean, economically speaking, that is a negative balance. Because if it's done by me or somebody else, but this doctor's hour is absolutely underpaid. And if your washing machine stops functioning and you call an emergency service for not functioning washing machines, if the guy on the other side of the line takes the receiver or the mobile, you already spend $50 or $100. Nothing solved yet. Just hello, that's $100. And talking 1 hour to a patient or a family about complicated side effects, the revenues are in the range of 30 euros. You would get the same amount of money if you say, hello, I don't care about your side effects, bye-bye, 2 minutes. It's the same amount of money. So that is absolutely crazy. I don't see any initiatives to address this point. So that's really the problem, and therefore, I mean, it's obviously very easy to point a sticky finger on those doctors who don't spend enough time with their patients. But if they are in difficult situations, they have to run their private practice, they have to pay their people, they have to pay for energy, water, whatsoever. If they would behave like that and talk 5 hours to 5 patients, this private practice will stop working within the month. It's not possible.
Absolutely. And because you just mentioned the washing machine, this is another big problem. Because every washing machine comes with a better manual than a treatment for the patient. Because patients don't get the support, the necessary support. So the question is, how can we overcome this? For example, if there is a new treatment, there could be something like a QR code, and then the patient is taking the QR code and is going into a digital world in a closed area. It's not publicly available. It could be a digital area where the patient can get a lot of support by experts, by patients, by documentation, by videos or whatever, how to deal with this issue. And then this is much more helpful than instead of going home and being alone with this treatment. I think these are the issues where we think to use digital tools and digital telemedicine and a lot of different issues much better than we have done this before.
I really, this is quite really good because it's quite thought-provoking and it, in a way, fits in with the discussion yesterday, Marcus. And I think it was your comment regarding if a new drug is approved, then an oncologist can just use the drug with no training at all. And that's really sort of struck a chord in a way that the training is important, and it sort of also fits in with the results of the INTRIGUE trial in terms of how we've improved in terms of managing the side effects of sunitinib, and in a way probably have enabled people to carry on with that drug for a longer period of time. And I don't have a sort of a magic answer in terms of how we improve the current situation, but I think training and using digital tools would be a very, very good way to try and approach this problem and hopefully improve it. Because as John and Peter mentioned, I've also been referred people who've gone through lines of treatment too quickly, essentially, without any real thought process. But anyway.
Robin, that gives me a chance to
I have a question.
throw in a little story I like to tell in this example with respect to your good old England. Our younger daughter, she's living in England, and she bought a small motorcycle, which she's allowed to drive. And she wants to buy a bigger motorcycle. And to be allowed to drive the bigger motorcycle, it's not a tremendous difference. It goes theoretically, but practically not anyway, because there is no unlimited streets in England. But to be allowed to drive this slightly bigger bicycle, she has to pass a new exam. And that will stop after 2 years, and then she has to pass another one if she wants to have an even bigger motorcycle. So that is completely different in medicine. As you said, once you are a licensed doctor, you can use whatever is available in the pharmacy, even if you cannot even spell the name of the drug or the disease that you are treating. But in driving cars or motorbikes or whatever, you need a special license for whatever. There are 10 or more license types in Germany and in other countries for tiny little difference, a very small, a little bigger, an even bigger, and a very big, and a giant, and so on. There it's possible, but in medicine, obviously not, and that's absolutely crazy.
We just had a question back here.
Yes, I just wanted to add, when we were talking about side effect management, we have the program, patient access program for Sutent for last 15 years. And initially when they were prescribed Sutent, there, as Marcus said, there's a manual with the prescription that goes, which said that there are different side effects that were coming in. So when we started the program, the first thing that we did was, read out what the manual had. Because for us, we were having patients who were coming from economically marginalized families, backgrounds, and they will not understand the manual that was put in. So for us, as a patient organization, it was I don't know how ethically or what, but it was something that we had to understand. Okay, hand-foot syndrome is one of the side effects. Yellow skin is one of the side effects. Because many a times, your yellow skin was, patients would come back to us and say they have got jaundice. because they thought that's another, illness that they have got because of whatever. So I think as an organization, what we did, or as patient advocates, what we did is getting into it and making them understand from the first time that there will be these things that will happen because you're taking this medicine. I think, and gradually, as and when they were comfortable with the medicine, they also knew how to handle their own side effects. They would tell their HCPs about it, and then maybe if it's a 12.5 dose of Sutin that they need to take, and still they had major side effects, the HCP would say, do it alternate days, because that's what the dose modification would go. If it was 37.5, then they would kind of do it. But it was like something which had to have an open communication with the doctors. And because the program was run with us, we would have a constant follow-up with the patient to understand how they are doing initially. So that's how we could, help them in getting to know how they could manage and do away with. Yeah,
That's a great, amazing service. That's great. So I just had one comment real quick as the microphone's making its way over there. And the quick comment is that we've discussed how we're all understanding the side effects and the side effect management better. So all of our centers have a way of approaching this, and what we do at Sylvester is anytime a patient starts a new therapy or it's their first TKI, we provide them with 4 documents. The first document is a detailed document on the medication. The second document is a document on how to take the medication. A lot of times we start at a lower dose and then dose escalate once a week to get to a higher dose slowly over time, so-called ramping it up. And then the third one is the common side effects, how to manage them, the hand-foot syndrome, the nausea, vomiting, the loose stools. These are the common side effects. This is how to manage them. We provide pictures also of what hand-foot syndrome looks like. And then the fourth document is what are the danger signs and when to call us and how to contact us. And then our nurse practitioners used to meet after 2 weeks, but now they're honestly meeting at 4 weeks. So the patient starts the medicine, ramps up, meets with a nurse practitioner at 4 weeks, goes through all of the side effects, uses any additional medications, and then goes for another 4 weeks, and then I see the patient.
Okay, so in the interest of time, we have one question here, and I think also a final comment maybe from Marco, and then we need to move forward into lunch, and then we will have another time in the afternoon.
Shouldn't we briefly go through the obviously two remaining slides? It's already 8, we're talking about 10, so maybe we spend 1, 2, 3 minutes on all of these slides. And
what in soccer they call added time.
Exactly.
At a time, okay.
And we know that is increasing over time.
Yeah.
So just a quick question. What is your opinion on including mental health support? So not just the psychological, but the pharmacological side of is that something that you ordinarily would take as part of a treatment in a guide, in a protocol on that, or is it something that you would leave for the counselors and psychosocial side of things?
So, if I've understood correctly, how do you approach the mental, psychological well-being of an individual person?
So prescribing, say for instance, an antidepressant as part of, rather than...
Got it. Yeah. So I think that's a really, really good question. And that's really tailored to the individual person. My sort of instinct, and again, this may be my bias, is to try and avoid pharmacological intervention. We do have good counseling services, but there's a really high sort of demand because they cover the whole hospital. But I try and get them involved quite early. And I think this is really difficult. And it ties in with Peter's comment yesterday about the art of oncology. And it's really, really hard. One of our patients who's been on imatinib for over 25 years now, she, the gist is really well controlled, but there are lots of other things going on in her life, and it's really difficult to really do one intervention or one thing to help with that. And I think it sort of takes time and trying to use all the available services. But my sort of instinct is to try and avoid pharmacological intervention, because I suppose any medicine can cause side effects. And I try to use the counselling service at the hospital and involve the local general practice in terms of trying to support a patient through a difficult time. But I don't have one magic wand intervention that will help all people, if that answers your question. It's a bit of a roundabout way of answering it.
Yeah. No, it's just that we've done some talking to patients, and one of the things that they said is if their doctor had told them that it was something, it was not a side effect, but it was something that they would experience and that it's perfectly normal for them to do that, they would have accepted it better and asked for it at a later stage, and got that input rather than, and that it didn't need to come from the nurse and that from the doctor. So it was medical. It wasn't that they'd, failed in some way now that.
Yeah. Well, again, your point's very well taken.
Okay, maybe a comment from Marco.
Just a brief thing. That's how our institution deals with side effects. We developed a sort of daycare facility where the patient can be admitted for the day, and we got both internal general practitioners going there, nurses, psychologists, psychiatrics, and this has worked very well for all the patients that live around the hospital or that can reach the hospital pretty quickly. And they're also starting to develop this tool via web. So as Robin said before, the online meeting with patients that is living miles away from our hospital but has been prescribed the drug here can be helpful for him to sort of try and understand and discriminate what is a side effect, what is an expected effect, what is not side effect of the drug, but something that aging after 10 years has taken into place with some other medications and stuff. So I think this has been developed over the last couple of years here in Milan. But I can see that our initial experience is very good with this kind of approach. But then, of course, every single system and every single hospital has got to develop its own approach in dealing with side effects of medication that we prescribe.
Okay, thank you. So I think we have two topics left, and one topic I think could be handled quite quick, about the plasma level testing.
Yeah, if I may, a rather radical statement. What benefit does plasma level testing have? Zero, none, nada.
Okay. Any comment?
We can discuss over lunch, Peter. Maybe it's my.
Okay. So then we have
maybe just one example. If a patient has a lot of toxicity and you do a testing and it shows a high plasma level, then you say, oh, now I understand the toxicity, and you lower the dose. Okay, you don't have a level, you have a lot of toxicity, you lower the dose. What's the difference? None. You have a patient with a lot of toxicity, you test the level, and it's low. What do? You lower the dose because of the toxicity. And therefore, maybe a little bit radical, as I indicated, but from my clinical practice, daily practice, understanding there is absolutely no need for plasma level testing. We never do it.
We when plasma level testing first came out and we only had imatinib, we did it in some patients on a protocol, about 200 patients, and we found it really not very useful at all. There could be a patient with a plasma level testing that had a level of 40 that was having a nice response to therapy, tumor shrinking. Yeah. And so we looked at the data and it wasn't really predictive of outcome.
Right. Okay. So Peter is tend to be radical, and so I think we got used to that over the last 20 years now. So we're happy with Peter being radical. I think what has changed in UK, at least in my practice, is the introduction of generic imatinib. So see, if you ask me the question about 2000, say 18, 19, 2020, I wasn't doing routine imatinib plasma testing, plasma tough level testing. So what we have realized is that patients who've been on Gleevec switched to generic imatinib. We saw some unexpected progressions, and we just looked at our data going back to 2021, and we set up a program in Cambridge doing imatinib plasma level testing routinely. And what we have found out is out of the 5 or 6 generic imatinibs we have, one of them we have consistently found that the trough levels were much lower, and half of them actually progressed. And we switched the imatinib from the generic B to generic A and repeated the trough levels came up, and the patient started responding again. It is, at the moment, it's anecdotal. At the moment, we only have 50 patients who have done that. But we have now incorporated plasma level testing as a standard of care in Cambridge in patients who are on generic imatinib. With Gleevec, we never had problems. If you go back to Ian Judson's paper from nearly about 12 years ago now, 14 years ago, that the imatinib levels go down with time because of the induction of the cytochrome P450 enzyme. So we know that over a period of time, the trough levels do go down. My practice has changed in the last 2 years, and with the introduction of generic imatinib, I've become a bit more careful about what the patient actually is absorbing. You can actually argue whether the plasma levels actually are meaningful, whether they reflect what's happening in the tumor. That's a different question, but I think I've got some concerns about where we are heading with the generic imatinib and what kind of generic imatinibs we're using in the clinical practice. Same thing happened with sunitinib as well.
Definitely for discussion at lunch, I think, Marcus, to be continued after the...
Okay, so I think last question or last topic is about the surveillance. It's about monitoring, follow-up, and these issues. Follow-up regime.
Well, if we go through the bullet points one by one, confident to be cured is depending on what you call confident. We do see very rarely very late relapses. So being confident means it's quite unlikely that something will happen, then it's probably 5 years. Being very confident or asking for a guarantee, it's never. Optimal monitoring for electric low-risk GIST. Actually, there is no data to support any type of monitoring because statistically speaking, it's extremely unlikely that something will be detected. We still keep the patient in monitoring every half year for a couple of years and then yearly. Also addressing the issue that John brought up many times, that these patients may develop other things. So we are not necessarily looking for a GIST relapse, but for whatever might happen. Long-term survivors with metastatic disease. If we look at the recurrence probability curve, the recurrence probability drops over time. So in the first 3-4 years, it's quite constant, 20% per year, but then it decreases substantially. So we do follow our patients on drug regularly every 3 to 4 months for the first couple of years, and then we extend to approximately every half year, because the likelihood of seeing a progression after 6, 7, 8 years is very, very low. So there we think less frequent follow-up is reasonable. The recommendation is very clearly either CT or MRI. We are increasingly recommending MRI due to avoidance of radiation exposure. We do not support ultrasound because this has no standard role in any guidelines. You can do it occasionally, but it's absolutely not a substitute for CT or MRI. And the last question, I would speculate yes, but I'm not aware of any data supporting this.
I think the French group looked at their data. And in the US,
I think with GIST.
Oh, not with GIST, with
It
sarcoma.
was soft tissue sarcoma, where the initial treatment, multimodality treatment, is more complex. There it's very well proven. Treatment outside an expert site costs you a couple % of life expectancy. But in GIST, it has not been proven, but I'm still convinced, yes.
Yeah, if you and it's been studied in the U.S. also. We did a study a few years ago in the U.S. from our center, and this was sarcoma. So you can choose to extrapolate or not extrapolate, but in sarcoma, the overall survival rate at 5 years was 10% higher if you went to a high-volume sarcoma center.
So in the lack of other data, we would be quite confident stating that being treated in an experienced site is clearly better than in non-experienced site, even if we don't have a real proof for that. But I'm sure none of you would be happy to be the proof that it's worse to be treated in an unexperienced center. So I think we need to extrapolate, and I mean, that's what we do and recommend treatment in the centers.
I agree. Lunchtime, right?
Thank you so much. So we will continue this discussion later on with the 10 rarely asked or unusual questions. They are much shorter, and maybe also we have a discussion maybe for 2, 3, 4 minutes per question, because in another session later on. Later. Yeah. So we will now continue with lunch, and because we are a little bit later, we would then continue, I think, 1:45. 1:45 means 13:45, and then we would start our session about rare and very rare types of GIST. So we are just 15 minutes later behind program. Okay, enjoy lunch. Thank you.